Hi, I'm Kevin Reavis, and I'd like to thank SAGES for the opportunity to discuss the topic, the endoscopic weight loss procedure has failed. Can I do a definitive surgical procedure? I have no disclosures. So we'll tackle the agenda. Bariatric surgery after endoscopic therapy. Spoiler alert, the answer is yes, we can proceed with surgery. However, there's some considerations that we need to follow after endoscopic therapy. For example, tissue adaptation from temporary devices which have been placed, residual material from permanent devices that are still there, the type of surgical operation that we'd like to proceed with definitively, and the etiology of failure of the endoscopic treatment. Was it patient-oriented, device-oriented, program-oriented, or just not a good match? And we want to determine the patient's surgical candidacy proceeding forward. So let's discuss temporary versus permanent implants. Temporary things include balloons, aspiration therapy, stents to induce satiety, shuttles to induce satiety, liners for malabsorption, resurfacing for similar type of thing, and magnets, which induce distal enterostomies. There are permanent implants, which include sutures and needles that can serve as anchors, as well as fastening devices. Definitive surgery really is around four major types of operations. There's laparoscopic adjustable gastric banding, there's sleeve gastrectomy, there's gastric bypass with Roux-en-Y reconstruction, and duodenal switch. And for today's discussion, we'll include two anastomosis and single anastomosis duodenal switch in the same group. Now, in terms of tissue adaptation from temporary devices, we'll talk about balloons, aspiration, stents, shuttles, liners, resurfacing agents, and magnets. So balloons preside in the stomach for typically around 6 months, and they can induce wall hypertrophy. And that stays around for a little while and needs to be taken into consideration after the device has been removed. Aspiration therapy is very similar to a gastrostomy performed with a percutaneous endoscopic gastrostomy placement. A stent across the gastroesophageal junction and gastrocardia to induce satiety has a fixation point across the gastroesophageal junction, and this needs to be acknowledged. Shuttles from the stomach into the duodenum can also induce tissue hypertrophy, and that needs to be taken into consideration, essentially a reaction to a foreign body. Liners from the esophagus, duodenum, which are anchored there and then proceed downstream in a malabsorptive effect, need to be considered with regards to the anchor site and reaction at that site. Resurfacing agents of the duodenum can induce quite a bit of inflammation, and that needs to be taken into consideration as well. And then finally, magnets induce an enterostomy downstream, and that needs to be taken into account at the time of definitive surgery. Multiple of these procedures being discussed are still pre-market. However, being aware that you may come across a patient who has undergone a clinical trial or an investigational endoscopic treatment is important, as are obviously those who have undergone treatment with devices and treatments which are available on the market. In terms of residual material from permanently placed devices, there are sutures and needles, which are typically left behind following endoluminal suturing. And those needles can serve as anchors to maintain tissue apposition and need to be acknowledged and dealt with later. Fasteners used in residual pouch reduction are made of a substantial amount of metal netting and plastic, and that also needs to be acknowledged and considered at the time of any type of revisional surgery and gastric bypass type reconstructions. So we'll address each of the four categories of definitive surgeries, starting with the laparoscopic adjustable gastric banding. This is an external device, so precautions are somewhat less than with the other surgeries. Following balloons, we need to allow that hypertrophy to resolve. Typically takes around 3 months or so as a window after balloon has been removed prior to any other surgery. Aspiration therapy, it's most likely helpful ergonomically to close down the gastrostomy site from the prior aspiration therapy while placing the laparoscopic adjustable gastric band. Stent across the gastroesophageal junction should be removed and allow that fixation point to heal prior to a band being placed. And then liners, particularly those anchored in the esophagus proceeding onto the duodenum, should be removed and allow the gastroesophageal junction anchor sites to heal prior to a band being placed. In terms of sleeve gastrectomy, this is a resectional procedure, and precautions are around both extraluminal as well as endoluminal considerations. When a balloon has been placed and removed or a shuttle has been placed and removed, we need to allow the hypertrophy to resolve, again, typically several months, of the proximal and distal stomach. Following aspiration therapy, that device is removed and the closure of the gastrostomy site is going to be likely incorporated in the resection, the resectional component of the stomach, which is will serve as a specimen. A stent across the esophagogastric junction needs to be removed, and again, the gastroesophageal junction anchor site allowed to heal prior to proceeding with sleeve gastrectomy. And then liners, particularly those anchored in the esophagus proceeding to the duodenum, should be removed, and again, allowing the gastroesophageal junction site to heal prior to sleeve gastrectomy. And then finally, sutures and their associated needle anchors should either be removed or avoided during sleeve gastrectomy because the suture anchors themselves, or the needle anchors themselves, have an anecdotal situations, jammed staple firings, resulting in additional need for tissue reconstruction at the site. In terms of surgical gastric bypass, this involves both proximal and distal divisions of the GI tract, and precautions include not only the proximal aspects of the stomach being balloons, allowing hypertrophy to resolve again, aspiration, likely closure of the gastrostomy site to allow ergonomic construction of the gastric pouch. Stents, again, removed to allow the gastroesophageal junction to heal, and liners, again, particularly esophageal anchored, to be removed and allow that area to heal. Now, we also enter the realm of distal small bowel acknowledgements, and that being with magnet enteroenterostomy creation. That enteroenterostomy will most likely need to be revised during Roux-en-Y gastric bypass. Again, sutures and needles left behind in the stomach following endoscopic suturing should either be removed or at best avoided to avoid having a jammed stapler at the time of creation of gastric bypass. And then finally, fasteners used in revision pouch reduction should most likely be removed if there's consideration of stapling a gastric pouch in a revisional operation, so as to avoid the substantial amount of metal and plastic netting associated with the fasteners of pouch reduction devices. And then finally, duodenal switch. This, as also noted with the gastric bypass, involves proximal and distal divisions of the GI tract. This time, however, also involves the duodenal bulb, which throws an additional caveat into the discussion. So precautions following endoscopic treatment prior to duodenal switch include, with balloons and shuttles, allowing the hypertrophy to resolve of both the stomach and the duodenum. Aspiration, again, closing the gastrostomy site is most likely going to be inherent in the sleeve portion of the duodenal switch. Stents across the gastroesophageal junction used for satiety, again, removed and allow that gastroesophageal junction to heal, very similar to that with gastric bypass. Liners need to be removed with both esophageal and duodenal anchor sites and allow both the GE junction and the duodenal bulb to heal, since the duodenal bulb will be transected as a component of the duodenal switch, and we want to make sure that tissue is healthy and not inflamed or hypertrophied. Resurfacing of the duodenum creates quite a bit of inflammation, and thus we want to allow that inflammation to subside and the duodenal tissue to be healthy and pliable for reconstruction during duodenal switch. So we want to allow that inflammation to resolve. Magnets, again, are going to create a distal enteroenterostomy, and that will most likely need to be revised during the duodenal switch operation. And then finally, sutures and the needle anchors associated with them need to be either removed or, again, carefully avoided so as to minimize the risk of jamming the staple firing during creation of the sleeve portion of the duodenal switch. So in conclusion, the safety and feasibility profile with each of these definitive operations following endoscopic treatment is really based on the residual effect of the endoscopic treatment, which preceded the definitive surgery, and of course the selected surgical procedure and how the two interact. We want to consider patient expectations and compliance, and again, determine the etiology of how they transition from endoscopic treatment to definitive surgical treatment, and make sure that we address their hopes, their fears, and their acceptances of the reality. This in total will allow you to provide optimal, tailored, programmatic treatment. With that, thank you. Thank you again to SAGES for the opportunity to present today.